The need for TAVI is growing exponentially in the UK and worldwide, and the indications are changing rapidly. The evidence base for TAVI is changing virtually every month. And so BCIS were keen to provide guidance as to what we thought was best practice based on the scientific evidence base. In other words, from the patient perspective, we wanted to agree an expert consensus as to who we felt should be getting TAVI, who should still be getting surgical AVR, and the mechanism that should be worked through to make that clinical decision. So we wanted to give a summary of what we felt was best practice, both in terms of who should get TAVI, but also how it should be delivered and which centre should be delivering it. Yeah, so we didn't make any distinctions between the valves because we are aware that different operators like to use devices that they're used to and that they are familiar with and have learnt TAVI with. And actually most centres use a variety of valves and tailor valves to specific patients' needs and patients' anatomy. The key recommendations really follow the literature in that we felt that patients at prohibitive surgical risk and high surgical risk should get a TAVI unless that was clinically impossible. Patients at intermediate risk should go to a heart team and be discussed, and TAVI should be a serious consideration for those patients. And patients at low risk should probably still default to surgical AVR, although we did make a statement that the literature is changing and Partner 3 had just been published at the time of our policy statement. And so we said that we recognised that the literature would probably change and this is a moving field. I think that was the subject of the debate today, which was a good debate. I think it allowed us to think about some of the issues. I think that to call it the default treatment is semantic in a way. I mean, I certainly think it is the mainstay treatment and all of my patients want a TAVI now, but we should be careful with the evidence base as it evolves. I think that it's a bit early to call it the default treatment. I think it's one of two good treatments for a nasty valve condition is a better way to think it. I think to call it default treatment is a bit divisive, and I think we've got to work with our surgical colleagues to tailor therapy to each of the individual patients that are presented to us, and we do that with the heart team. Both treatments are good, but I think that the literature would support the use of a transcatheter option in inoperable patients, in high-risk patients. I think in intermediate patients at the moment, we would carefully assess those patients, and if we felt that they were really suitable for TAVI, we would default to TAVI because it's less invasive and less traumatic for the patient. I think the evidence base for the low-risk patients is very early at the moment. There probably is only the two studies on the low-risk group, one of which shows equivalence with surgery and one of which shows a preference for TAVI, but that is a selected population. And I think we need more data before we can make sweeping statements about low-risk patients. I think it's worth saying that much of the literature looks at risk and doesn't concentrate on age. And lots of the intermediate and low-risk patients were actually quite elderly. So certainly the intermediate patients were low-risk elderly patients. And I think that age should come into it because if you do move into a younger patient group, doesn't matter about their surgical risk, but if you're dealing with patients in their 60s, for example, then other issues do become more prominent, which are important when making this selection. For example, the incidence of bicuspid valves will increase, and that may be an issue for transcatheter therapies. But also if you have a therapy such as TAVI, which has a slightly higher pacing rate, then a pacemaker in a 65-year-old is much more of a big deal than a pacemaker in an 80-year-old. I think the pacing issue is an interesting issue, and I suspect that the pacing rate with TAVI is going to be lower in younger patients because they have a more healthy conducting system. So that is a bit of an imponderable and unanswered question at the moment. But I think we need to be thinking not only about risk but about age and trying to plan the patient's trajectory over the remainder of their life when trying to pick the best therapy for them. Well, there are a wide number of things that we go through in a TAVI workup that allow TAVI to be possible in terms of access, vascular access, in terms of the valve size, of the valve, the nature of the calcification, the bicuspidity of the valve. And then there's also the important issue of coexistent cardiac pathology, in particular other valve disease and coronary disease. And this goes back into my previous comments about younger patients, is if they have, for example, very severe three-vessel coronary disease, heavily calcified left main disease, and significant mitral regurgitation as well, well then surgery does offer the option of fixing all three of those things, the aortic stenosis plus these other two things at the same time, whereas TAVI doesn't, and you would then have to embark on a multiple transcatheter plan for that patient if you needed to. So I think, in answer to your question, there are a number of things which rule out TAVI, but fewer and fewer. And I think that if you get into a population of, say, 80-year-olds with aortic stenosis, it's not that often that we turn patients down for TAVI. Maybe 5% of the time you find something, or even less, 2% of the time you find something that means that TAVI is not possible. So usually you can do it. Yeah, we'll concentrate on just the durability first of all. Durability is being looked at, and it's right that it's being looked at, and we do need more data. There's no question that we need longer data. One of the issues has been that we've been doing TAVIs on elderly patients, and therefore we haven't had long-term follow-up. So we're just getting to grips with longer-term follow-up, but none of the studies indicate that there's an issue. And in fact, in many regards, TAVIs should last at least as long, if not longer, than surgical valves, because they have a very good hemodynamic profile when we put them in because of the absence of a sewing ring. So I can't see durability as being an issue, but I do acknowledge that we need the proof that it's not an issue as we go forward. And the valves will behave slightly different because some of them are crimped down to get them through the catheter, so it may be that there are some inherent issues with the tissue of the leaflets which makes them more prone to early thrombosis. And there's a lot of work going on in that field, but at the moment I don't see a message or an indicator from the literature that suggests that TAVI durability is going to be a major shortfall of the procedure. There's lots and lots of TAVI valves that have gone in, more than 1 million worldwide, and it just doesn't seem like durability is going to be an issue. But I could counter that by just saying that we do need to know for sure. I would also mention that durability hasn't been well looked at in some of the surgical valves, and certain surgical valves don't last very long and they come back early as well. So I think we have to look at surgical valves and TAVI valves to get better data about durability. And I think the spotlight on TAVI durability also has to shine on surgical valve durability so that we can compare the two in a fair way.